Hi there, my name is Fiona O'Donoghue and I am a senior speech and language therapist at Beaumont Hospital. I work in radiation oncology, supporting patients from their initial consultation regarding radiotherapy up to 5 years post their treatment. In this video, I am going to give advice to SLTs who may encounter patients who have been diagnosed with brain cancer. Here are the top things to know about how speech and language therapy can support people after a brain tumour diagnosis. Communication challenges are common after a brain tumour treatment and can include dysarthria, aphasia and cognitive-linguistic difficulties such as reduced attention, reduced processing speed or word-finding problems. So key points. Early identification is important. A quick screen can flag subtle but significant difficulties. Consider something simple, such as the quick aphasia battery or a Western aphasia bedside assessment. If the patient is presenting with higher level language issues, a condensed Mount Wilga screen may be beneficial. What is most beneficial is when these patients get a pre-treatment assessment, be that surgery, radiotherapy, so you have a good baseline assessment. Family members are instrumental in the avoidance of communication breakdowns, easing of frustration, and ensuring good flows of communication. While it's important to work directly with the patient, don't forget the importance of working with communication partners to ensure a holistic, achievable approach. Understanding the patient's treatment plan, individual goals, current skill level, and prognosis are an essential part of your management. This means often formal assessment is not indicated or warranted, and diagnostic therapy or informal screens are more appropriate. Another consideration is perhaps active therapy sessions are not going to be as valuable as compensatory approach might be. Often it can be about maintaining current level of function and supporting the communication partners. Dysphagia can arise from the tumour itself, treatment effects, or associated fatigue and deconditioning. It may present as weight loss, coughing on PO intake, prolonged meal times, or frequent chest infections. In line with the National Cancer Strategy, the patient and their autonomy should be at the centre of our decisions. SLTs should be alert to subtle signs, not just overt choking, but changes like unexplained weight loss or avoidance of meals. Infection markers, such as CRP rising, may indicate an underlying swallow issue. Consider the part of the brain that the cancer has been located. For example, cerebellar or brainstem masses may put someone at risk of silent aspiration. Whereas if there is a frontal lobe mass, consider how cognitive changes may impact on safe eating and drinking. Lastly, always consider the patient's wishes. Avoiding chest infections may not always be the priority for the patients, in spite of the risk. Some may choose to eat and drink with acknowledged risk of aspiration in favour of comfort, and this is an okay decision to make as long as their medical team is aware and the patient fully consents. Finally, looking at both the dysphagia and the communication side of things, always consider where the patient is at in their treatment. For example, someone who is in the middle of their radiotherapy may not be reflecting their true baseline. As well as someone who is currently taking steroids, this may be masking underlying difficulties. It is also important to consider the psychosocial impact of the diagnosis, as well as the impact of fatigue on performance. Always consider onward referral to MDT members, such as occupational therapy and dietetics, for holistic care of the patient. I hope you find these tips useful and beneficial for your future patients. For more resources and to find out more, please follow the links attached to this video.